All right, let's go. Open the document first. All right, so for this, we are only going over the path. Path is the color red. Um, so I'm gonna skip the pharma micro. I'm gonna make videos for pharma micro in the future. So let me grab my highlighter. So the way it's gonna work, I've already went over these, highlighted I think what's the important stuff. So we're gonna go over the highlighted stuff for most of the questions. That way it will save us time, and then I'll explain why the answer is so. You should pause and try to guess the answer yourself before I do that, okay? And I'm gonna do something like this because I have the answers on the right side. We don't want to be looking at the answers right away, okay? All right, question three. We got 34-year-old multi-gravidal. That means the woman has had multiple kids so far. Fever on left breast. Gave birth without complications 2 months ago, so she's probably breastfeeding. Uh, History of mitral valve replacement complications by endocarditis. She's had endocarditis. There's a mass in her left breast. Mother had breast cancer at age of 40. So this is also important. She had cancer as 40. This is like 34. So it's younger, but not that much younger. Breast ultrasound shows fluid collection under the skin. Needle biopsy, 15 millimeters, cloudy yellow fluid. All right, which are following uh, is the cause of underlying condition. So for me, the fever and the fact that she's had a baby recently are the biggest important factors, and that to me leads to mastitis. Let me choose a bit. Let me just use my highlighter. Mastitis. So yeah, the answer is A. All right. 40-year-old woman comes to the physician because of 48-year-old, 10-pound weight loss in 6 months. She's got heat intolerance, meaning she's always hot, palpitations, fine tremors, kind of sounds like hyperthyroidism. Physical examination shows, yeah, exophthalmos and enlarged parotid, so some sort of hyperthyroidism. Which of the following most likely to be seen in the patient? Okay, so the other thing I want to share with you guys is that the way I do multiple choice questions is that I always compare A, B, and then out of A, B, I keep my favorite and then play the winner with C. So I'll show you how. Decreased T4, decreased radioactive iodine uptake. Well, obviously we said hypothyroidism, so A it can't be. So now we compare B and C. So we had decreased radioactive iodine uptake and decreased resin T3 uptake. So radioactive iodine uptake is they're both wrong, but radioactive iodine uptake is decreased when you have hypothyroidism. It's basically like if this is your thyroid, it's like how many new iodines is taken up, and if it's hyperthyroid, you should be taking more iodine. Decreased resin T3 uptake. So resin T3 uptake is basically indicator of how much thyroid binding globulin we have, right? So if we have high levels of thyroid binding globulin, it's basically competing for thyroid hormone with these resins, right? So if we have decreased resin, so this guy can bind this or this, right? So if we have decreased uptake by resin, it means we have high thyroid binding globulin. It doesn't have to do anything with our thyroid hormone per se, right? So that's not also our answer. Decreased plasma concentration of thyroid stimulating hormone because we have hyperthyroidism, and because it sounds like the only thing that can I can think of because of ophthalmus exophthalmos is something like Graves. I would say so. It's primary hyperthyroidism, meaning it's produced at the thyroid, and the cause is not increased TSH, right? And that's a rare cause, anyways. Um, so I'm gonna compare it to D, increased plasma concentration of thyroglobulin. Yeah, this does happen when we have Graves, right? Because the follicles are getting destroyed. Sorry, not the follicles are getting destroyed. Everything is kind of like on. The thyroid is working really hard, so some of the thyroglobulin gets into the plasma. To be honest with you, I didn't get this question right the first time I tried it. So for the questions I didn't get right the first time I tried it, I'm gonna put like this mark over here. You'll see which ones I get right. So, but I think the answer to this one is in fact E. Yes. Oops, we saw the next question, but I'm gonna make sure I don't do that again. All right, so for this one, is a 14-year-old has cystic fibrosis, has abdominal pain after fatty meals, right? What does that make you think? So, cystic fibrosis common cause of pancreatic failure. That means not having enough pancreatic enzymes, right? I should say exocrine pancreatic failure. And this girl already has pain after fatty meals, so probably not enough enzymes or whatever to break down fat, and then so she's had has problem with fatty meals. Her mother says that past several years she's had bulky, greasy stool floats on the surface of water. Right? What does that mean? So description of stratorrhea, which means basically greasy stool. Sometimes they can describe this as it stays. It's hard to flush, and the reason for that is fat is lighter than water. So when you put it like when you do your business and the poop is like it's like the poop is always above the water, so it's hard for it to get flushed. Beautiful picture. Um, okay. Serum amylase, lactase, and trypsinogen are elevated, right? So we got indicators of pancreatitis, and it's kind of a chronic thing. Shall the following best explains the laboratory findings, right? Uh, so in the what happens basically is that you have if this is your pancreas, right? There's like a duct in the middle that like gets all the stuff from the pancreatic tissue because of the in cystic fibrosis because there's thickened mucus, so there's going to be blockage of this uh, there's going to be more blockage, maybe like maybe not here but in the more smaller ones there's going to be blockage, and when you have blockage you start having kind of like you start digesting the pancreas itself, you start killing some of the tissue because the enzymes get activated prematurely. Right. So now let's read the choices. Activation of enterokinase. So enterokinase is in the intestine. I think, but this is not. I think this is the enzyme that I'm kind of sure that this is the enzyme that activates trypsinogen, and the trypsinogen activates everything. And this enzyme enterokinase is exclusively in duodenum and not in the pancreas. So this doesn't even make sense. Activation of trypsin inhibitor. What we have is activation of trypsin, right? And that's what is our problem. Out of the digestion of the pancreas, I like to keep this excessive secretion CCK. I can't really think of anything that actually causes this, but CCK, cholecystokinin, right? Kinin movement. Chole, bile, like cholangitis, bile sac. Cholecystokinin, it basically what it says is that it makes the bile sac contract, right? That's what it does. And so if you have excessive CCK, you'd have more bile stuff in your duodenum. You'd have, and they help with fat absorption. So another right answer, not a right answer for specifically this question, but another thing that could cause diarrhea is low secretion of CCK, and that's seen with when you're on octreotide, I think is how it's pronounced. So, but this is also not option. Gallstone obstruction could give you this. Why? Because you're inhibiting bile from entering the GI system, and bile is necessary for breaking down fats. But in this case, she's got cystic fibrosis, and the cause is C. We already saw the answer for this, but let's take a look. See. Okay, this time we didn't see the answer to this question. So, how long has this been going? I don't even know. This is 1:36 now. A 34-year-old multi-gravital woman gives birth 37 gestation. Newborn examination shows a firm right testicle, right? So baby boy has firm right testicle. The mass is removed. Grossly appears homogeneous and yellow-white in color. Okay, okay. Okay, so epithelial lined shows epithelial lined spaces that have flattened or cuboidal epithelial cells with uh, vacuolated cytoplasm containing eosinophilic halon-like goggles. Now, to be honest with you, if they didn't say sure dual bodies, I wouldn't know what the fuck they're talking about. Um, so they're talking about this. What these basically are is they like a kind of glomeruli like structures. Yeah, it also says glomeruli, primitive glomeruli. The eosinophilic cytoplasm of the globulin tumors most likely shown. So, all right, it's asking what will we stain for? Uh, so the type of tumor that makes the glomeruli, I think, is called uh, the the yolk sac, or the I think the fancy name for it is the endodermal sinus tumor, right? It's basically the yolk sac is when the embryo is forming like this. There's like this thing that connects the inside to outside, and it's like prominent in the beginning, but it kind of goes away. So this is a tumor of that tissue, apparently. All right, so let's go through the choices. Alpha fetal. So what does it produce? I think it produces. It doesn't have estrogen receptors, right? That's obvious. Human HCG. Okay. I mean, this is not even. It's not HPV. Placental alkaline phosphatase. So placental alkaline phosphatase is in seminomas, right? This guy, what does produce is alpha fetoprotein, and the way you can think of the alpha fetoprotein is that description I gave you is from like a fetus. It's like a primitive subtissue. Okay, I try not to memorize these things. That's why I have to go through it to get to the final answer. This is a micro question 9. All right, 79-year-old comes to a physician because of dystonia, resting tremor, rigidity. Okay, so this guy got kind of Uh, dystonia, resting tremor. Okay, this sounds like Parkinson, but you don't even need to know what that is, like about Parkinson. This sounds like is that in the uh, basal ganglia, you have low dopamine, right? That's what the characteristic is, like dystonia, like, and resting tremor, rigidity. Bradykinesia. That's like low dopamine. So he's 24-year-old diabetic type 2 and recently started on a medication that treated diagnostic with gastrointestinal disorder. Which of the drugs? It's a drug question, but there's a lot of physiology and pathology that goes into it. Which of the drugs most likely described is prescribed? Okay, so this guy, and what's interesting is that, so he has Parkinsonian syndromes, which means basically low dopamine in the basal ganglia, right? Now, why? Because of one of these drugs. So we're trying to think of like a D antagonist. So that's one way to look at it. And the D antagonist is metoclopramol, right? Um, it and these are just like they're just not D antagonists. But the other way to think about it is to be like gastrointestinal. So that's how I would think about it. But the other things that they're giving us also make sense. For example, gastrointestinal disorder is probably talking about gastroparesis, which is supposed to be your stomach. Your stomach isn't moving food through itself. It's gastroparesis. The stomach is paralyzed. Happens in diabetes because of nerve damage. Um, and you give them erythromycin or methacorpol. Well, I guess erythromycin makes a lot of sense here, but it uh, doesn't cause Parkinsonian syndrome. The other thing is that methacorpol, if you remember, it has anti-alpha effects. It also has anti-muscarinic effects. Anti-muscarinic effects can lead to like dementia, stuff like that in an old person. Anti-alpha, you already know what that does. You know, um, bunch of stuff, but that's just like I'm not sure if it leads to hypotension, but causes anti-alpha and anti-muscarinic effects. Oh, the other thing I was gonna say is that, so just like antipsychotics, that if you're on them for a long time, you get tardive, meaning delayed dyskinesia. Uh, these guys can lead to that too. So long term, you put a patient on this, they get tardive dyskinesia. That basically is because of that. So let's say this is the neuron in the basal ganglia. It has the D receptor here. The D receptor is always blocked, so the neuron will upregulate the, like many more D receptors because of just like how feedback systems work. So now, because it has so many receptors, it's super, super trigger happy. So in tardive dyskinesia, it happens after a while of like overexpressing these, and then it just randomly triggers with like the slightest dose of dopamine. So you get like twitches and stuff like that. It happens after antipsychotics. It also happens after this drug that is a D2 antagonist. Uh, okay, 10. 83-year-old woman comes to the physician because of early mental issue ulceration of the left nipple. Okay, so you got ulceration of the and itchiness of the left nipple. There's some discharge for the past month. Uh, she's tried some over-the-counter stuff. A biopsy shows scattered cells with clear abundant cytoplasm located within the epidermis of the nipple. That sounds like a lot of like pageant disease of the nipple. So if this is the your basal membrane, in pageant disease you have like cells all over, right? But in pageant disease, you'll see like kind of neoplastic cells that are like described, but like they're like kind of random. They're not next to each other, which indicates these cells aren't produced here. They're produced somewhere, probably in the breast. Like if this is the nipple, they're produced like here, or they're produced in the like ducts, and they kind of like move their way out to the nipple. And they're positive for cytokeratin. I just the only thing from this is that it has keratin, so it's an epithelial kind of cell, and we can already tell that. But the fact that it's in the epithelium, uh, and so it's asking what's the original condition. I can already answer this. It's a ductal carcinoma in situ, so it's a carcinoma in the duct. This is a duct that exists here, and then the cells are walking up to the nipple, and we're seeing symptoms of that. So B. Let's make sure I show you the answer to 11, but this is B. All right, 11. So a 33-year-old comes to a physician because of recurrent headaches, visual change, libido loss, erectile dysfunction. Okay. As past year visual field testing shows uh, lateral defects. Yeah, lateral defects. Lateral so it shows decreased luteinizing hormone and testosterone. Normal, and a normal thyroid stimulating hormone. Interesting. Which are following most likely diagnosis. Okay, so this guy basically, if you remember, the way the nerve for the eye works is that if it's this left, like this left eye, this is right eye. Usually this is right, this is left. We're looking from the bottom. The nerves from this side come cross. The nerve from this side come cross. And these guys just like go a merry way. Does that make sense? That doesn't make sense. It's the other way around. So the nerves from this side are nerves from this side come across. These go down, right? So and these are next to the hypothalamus. So this guy has a tumor here that is causing a lot of things. Causing low libido. Uh, it's causing. I mean, the tumor is here, so it's causing like lack of vision on the lateral sides. Because remember, these guys hit these neurons, and then so these neurons are responsible for lateral. This is called bitemporal heminopsia or heteronomous heminopsia. It's the good old MB2 or 3 or whatever reference for you. So it's causing low libido. It's causing, and how does that do that? Because does they have also, this is a guy, it doesn't have galactorrhea, but it was a girl, it would also have galactorrhea. So it's producing basically prolactin, and then prolactin is decreasing, um, like the GnRH, is it called? I don't know, the gonadotropic hormone. Yeah, the gonadotropic hormone. I guess this is a releasing one, but this is the gonadotropic hormone is decreased, so you'll have less LH. Oh, I guess the gonadotropic hormone is LH and FSH. So it's decreasing LH and FSH production directly because of its presence in the pituitary. Um, but it has normal thyroid stimulating hormone. Good for him. Hasn't gone that bad yet. So let's look at the choices. Craniopharyngiomas is like more common in kids. It has like cholesterol crystals in it. Uh, and I don't remember this exactly. I'm gonna look it up. Here, let me put like a star somewhere. I don't want to look it up and come back to it at the end of the video, maybe, or put it in the description somewhere. Craniopharyngiomas, I think they also have a difference in terms of their placement. One of them is above uh, a certain line, one of them is below a certain line when you compare craniopharyngiomas with uh, like just tumors of the pituitary. But get back to it. I think craniopharyngiomas is behind, is under the pituitary. Um, but I'll get back to this later. Idiopathic pan. So it's not kind of idiopathic. You kind of know what it is, but pan hypo. It's also not pan because you have got normal thyroid, right? Isolated SHS deficiency, pituitary infarction could cause this maybe, but it's prolactin or not. But this happens a lot in a pregnant woman who loses a lot of fat, blood. So one thing you can think of is a placental, like not previa, accruda, or those things that placenta like invades deep into um, the myometrium or the endometrium, and they cause bleeding, so they can lead to infarction of uh, the pituitary. I mean, to be fair, this thing can also uh, it can't cause infarction. It can cause hemorrhage, and I think it's called apoplex, pituitary apoplex, and that can give you acute kind of headache and like loss of pituitary function after that. All right, it's a bunch of micro questions. Boring, boring micro. Oh, we didn't check the answer for that. E, of course, of course. I did go through the answer to make sure I don't like. Towards the end of the session, I haven't gone through the last 20. So 44-year-old, sorry, 46 chromosome. So no extra chromosomes. X newborn. So the chromosomal sex is female. Born normal time, ambiguous genitalia. So ambiguous genitalia means high androgens. Um, that just means it's not 17 for me right now, because 17 is needed to make androgens. Laboratory studies show blood sugar is low. Okay, bonus questions. Why would blood sugar be low? We'll get back to it at the end of the question. Potassium is high. Potassium is high. It means we don't have a lot of mineralocorticoids. We're not talking about aldosterone. We're talking just about mineralocorticoid effects, right? If you don't have any mineralocorticoids when you're comparing our 21 to 11, remember that 11 is lower down the chain than 21. So if we have 21 inhibited, you're kind of inhibiting all the lower guys. When you have 11 inhibited, you're only inhibiting the last products. The key is to know is the mineralocorticoid pathway. So let's say this guy leads to this guy leads to this guy, and this is like aldosterone. Uh, so this is 11 beta, this is 21 beta, right? This guy is called 11 deoxycorticocortisone, right? Something like that. And this has mineralocorticoid effect. So when we knock this one down, we still have mineralocorticoid effects, right? When we knock this one out, we don't have anything. So the fact that this guy has high potassium, it shows you this one is knocked out, right? Let's read to make sure. I don't even like. Yeah, sure, whatever. So it's a 11, it's a 21 beta, right? Now, the reason we have low glucose, I hope you thought about it, but that's basically with all these congenital adrenal hyperplasias. Please, 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 please remember the main problem is you don't have cortisol, right? That's why, because you don't have cortisol or glucocorticoids, you will have adrenal hyperplasias. That's the main reason, because ACTH will be high. So I mean, the disease is named after not having cortisol. And the reason that I'm talking about this is that that's why we don't have glucose. If you remember, glucose, one of the things it does is that it kind of promotes gluconeogenesis, right? It increases blood glucose level. And this kid, because it doesn't have any, has super low levels. Okay, let's see. We got it right. Yeah, of course. All right, so it's not hard. Thank God, one GI question after 52 years. So 50-year-old woman, kind of itchy. What does that immediately think make you think in the context of a GI and jaundice? It's like the conjugated, non-conjugated stuff, or mostly conjugated stuff, is getting out into the tissue, conjugated bilirubin, and causing itchiness. Why non-conjugated? Because non-conjugated is not super water soluble, so it won't be able to travel around. Laboratory studies shows increased conjugated bilirubin and increased alkaline phosphatase. So, in addition to what I said before, we also have some sort of inflammation in the ducts of whether intrahepatic or extrahepatic. Liver biopsy shows grammatous inflammation centered on small bile ducts within a portal space. So, first of all, granulomas, that's um, are primary biliary cholangitis, uh, right? And it's the one that happens in women, but don't think of it like it happens more commonly in women. But if they give you a question that's like a man and they give you this description, it's still primary biliary cholangitis. Primary biliary cholangitis will give you granulomatous inflammation. The other one, primary sclerosing cholangitis, has fibrosis. And that's what sclerosis is referring to. Also, this one only happens in the intrahepatic bile ducts. No evidence of cirrhosis yet. Diagnosis of diagnosis made. Just following what you see in the patient. So, Cianca is always Wigner's, always Wigner's. Know it as Wigner's, and then that way you can remember it well. This is just Avalon antitrypsin. Uh, so this is elevated hematocrit. I can't think of what they're trying to refer to here, but basically, so this guy is with uh, primary sclerosing cholangitis. This guy is with primary biliary cholangitis. Um, so the way my friend memorizes like what's this is that B for breast for woman, S for schlong for women. B, right? Okay, micro. So 22 is the one I got wrong. So I'm excited to see what it was. They're not that they're hard. It's like I make stupid mistakes too. So 35-year-old physician, blood tinge discharge from nipple. So nipple has blood tinge discharge 35. Okay, temperature is normal. Don't skip over the vitals, by the way. Read them. Pulse is 72. Respiration is normal. Blood pressure is normal. Everything's normal. Just got a mass and just got a discharge from one nipple. Nipple is it shows small papule, subareolar tumor. So as a tumor, tumor is surgically resected. Um, okay, so how do we know if it's malignant or benign? The general discussion when you talk about what happened. Fuck, give me a second. Alright, stop working for some reason. The general discussion of why malignancy versus benignness, you should look at a capsule of a tissue, right? So, like, let's say if this was talking about uh, follicular carcinoma, then the capsule would be super important. So, in this case, or it's like how atypical the tissue architecture looks, meaning how atypical the way the cells are arranged next to each other is, and how atypical their nuclei is. So those are like kind of histologically important things. But malignancy is kind of like invasion out of this capsule. Uh, so for this, basically, I remember this from pathoma straight up. Um, Remember that in the breast, I'm just gonna use. So we have like the ductal things, the ductal cells, and the thing that's special about the breast, we also have my epithelial cells that contract and propel the milk forward. And when we have these two together, it's kind of an indication that the tissue hasn't morphed into something else yet. And it's kind of like a hyperplasia. But when you have like only one of them, when you have only, shit, but when you have only, let's say these guys, and then like, no, not the muscle guys, the my epithelial cells, then okay, maybe there's malignancy. So when you have both epithelial and my epithelial, you're good. You're not more than. Oh, 22, exciting. Okay. So 20